The next lecture in the YPF is Atypical Diabetes, Moving Beyond Type 1 and Type 2 Binary by Dr. Dr.A.A.I.D.Athurugiriya, Senior Registrar in Endocrinology, National Hospital, Kandy. Dr. Athurugiriya is a Senior Registrar in Endocrinology, National Hospital, Kandy. She had her MBBS at the Faculty of University of Peradeniya with second class upper division with distinction in medicine, surgery, gynecology, obstetrics in 2017. Had her MD in medicine at the PGIM, and she is proficient in managing a wide range of endocrine disorders and conducting academic teaching. She is passionate about improving patient outcomes and advancing endocrine care in Sri Lanka. So the topic is an atypical topic, atypical diabetes, moving beyond type 1 and type 2 binary.
Hi, good afternoon. I'm Dr. Dr.A.A.I.D.Athurugiriya, Senior Registrar in Endocrinology from National Hospital, Kandy. It's a pleasure for me to be here today, speaking to you all on atypical diabetes, moving beyond the type 1 and type 2 binary. So this is my overview. So first we look at why is it binary? So why do we go for this binary classification? It's because we are used that when a patient comes to us with features of diabetes and the investigation supporting diabetes, we try to categorize this patient to which does he belongs to. So what runs in our mind is, where does he belong? Is it type 1 or is it type 2? That is the binary thing. So it comes from this because of the prevalence of diabetes in the world. So majority of the population in the world belongs to type 2 diabetes. It accounts for about 90.9%. And then the other major category is type 1, which accounts for about 5.8%. And that's why we try to think in this binary fashion. But there's another small percentage of 3.3%, which is hidden in between these patients. So what are these other types of diabetes? Those are secondary diabetes, which includes the endocrine disorders, drug-induced diabetes, genetic disorders, and pancreatic disorders, which are well known to us. So is there any other form as well? Yes, of course. There is this atypical diabetes. So what is this atypical diabetes? It includes the forms that do not neatly fit into type 1, type 2, or the secondary diabetes criteria. So some say non-type 1, non-type 2 category as well. So mind you, now this cohort is estimated to be 5 to 11%. So that means the number is rising, and we have grabbed these patients from the cohorts of type 1 and type 2. So now we have to change the statistics of this world, and the numbers of type 1 and type 2 will invariably reduce if we do a proper statistical analysis now. So why do you need to diagnose accurately this type of diabetes? It's because we can arrange the precision medicine for this patient. We can give the personalized care for this patient, the accurate treatment for these patients, and it improves the prognostication. Not only that, we can have informed genetic counseling. So that's why we need to identify this cohort. So we'll quickly move through the major categories of atypical diabetes. That is monogenic diabetes, syndromic diabetes, mitochondrial diabetes, lipodystrophic diabetes, and ketosis-prone diabetes, latent autoimmune diabetes in adults, LADA, and the fulminant diabetes. So we know about all these groups. It's not a new thing for you, for this audience actually. So I would like to tell you now, there is a worldwide network called Radiant, the Rare and Atypical Diabetes Network, which is running a study currently in the world to identify the rare forms of diabetes, atypical forms of diabetes, and with the improved facilities and advancements, they are detecting more and more types of diabetes. Earlier, we used to say there are four types of MODI. Now, very recently, they have detected, in addition, 6 types as well. So this category is improving. So You can have a look at this. It's available online, so you also can see and get an idea about this. And if you also have patients who will benefit from them, they can be included into this network. So next, I will move on to a new concept, the endotype concept. Suppose a patient comes to you, a young, thin male patient in his 20s with asthmatic symptoms. And his mother, who is in 40s, has diabetes. So he has a glucometer at home, so he has pricked himself and checked his blood sugars. So it's 240 lab. And then because of the awareness, he has gone to a lab and got done an HbA1c also. It's 8.6 or something, somewhere around that. So this patient comes to you. He's thin-built, a young male with asthmatic symptoms for about 1 month duration. No features of, no history of decay. So at that moment, what do you think? So he being a young, thin male with diabetes and without features of insulin resistance, so we invariably think, okay, this patient is having possible type 1 diabetes. And we don't have facilities to accurately diagnose this because we are a resource poor setting. So we don't have easy access to C-peptide and other GAD antibodies. So we clinically classify this patient to a phenotype and we start to manage him as type 1 diabetes. Now, the world is moving away from this clinical phenotype. So they try to look at the pathophysiology behind these patients and then try to arrange their management in that line. So this is described in 3 axes which are related to the defects in insulin secretion and defects in insulin sensitivity and defects in islet autoimmunity. So the categories that I mentioned you earlier falls into these areas, the insulin secretion defects and insulin sensitivity defects and autoimmunity defects. So this endotype concept comes into play. So they can share either 1, 2 or all 3 pathophysiological pathways. So we'll quickly go through the types of atypical diabetes. So monogenic diabetes, it is not unknown to you. This includes the MODY, the maturity onset diabetes of the young, and neonatal diabetes. So they have a strong family history and it is autosomal dominant. And usually they present to us before the onset of 25 years. But they can go up to 35 years as well. And the genetic, we can get a proper history, examine these patients, and don't forget to draw the pedigree chart because they are autosomal dominant. So it will show the clear pattern of inheritance. So though we don't have genetic assessment facilities, we can get an idea depending on this pattern whether could this patient have monogenic diabetes. And it is good to do the genetic assessment because, for an example, if the patient is having GCK mutation, the glucose set point is higher. So their glucose levels are going to be high anyhow, but they don't need treatment. So we can observe these patients. Though you are going to treat these patients also, anyhow their sugars are going to be high, not sky high, but to a marginal level, it's high. So that is the importance of identifying these patients correctly. And the other category is the lipodystrophic diabetes. These features are from an actual patient presented to a diabetes clinic at NHSL. So she's in early 20s and coming with asthmatic symptoms. Look at the first picture. There, she's having acanthosis nigricans, and fairly the fat content is preserved there. So at a glance, you can think, okay, she's having acanthosis nigricans and having diabetes. Since the type 2 is very common and we commonly see in our young population as well, okay, this lady can be having type 2 diabetes. But if you expose her properly and see, you can appreciate that she's having a prominent musculature and she has phlebomegaly. And the other thing, and they have fat loss in hips, buttocks, and limbs. And the other feature is they usually, the fat distribution is such that they have fat in their face and cheek. So this girl, this girl has actually partial lipodystrophy. In adult endocrinology, what we see is this type of patients, not the congenital ones. They will present in their childhood. So what we have to keep in our mind is this category. So we might misdiagnose these patients, and they have, in addition, this hypertriglyceridemia. So they have very high insulin resistance. They can be treated with metformin and thiazolidinediones to reduce the resistance, and then they require high doses of insulin. But the ideal treatment is metreleptin, which is a human analog of leptin, which is FDA approved also, but unfortunately it's not available for us. So we quickly move through the other categories, the LADA, which is not unknown to you. It is also called now slowly progressive insulin-dependent diabetes. They share type 1 and type 2 risk genes. So they have this phenotype of type 1, mixture of phenotype type 1 and type 2. And the typical feature is they require insulin at least after 6 months of their diagnosis. And then ketosis-prone diabetes, they present with DKA. These patients do not have the classical features of type 1 diabetes, and they may look like type 2 diabetes patients. And at the beginning, when they present with DKA, we have to manage with insulin, but later on we can put them safely on oral hypoglycemic agents and monitor them closely. And the other type is the mitochondrial diabetes. It has a maternal inheritance, and the patients may present with diabetes along with sensorineural deafness. And they can present from their early childhood, but can go up to late 40s as well. So they are also, if you draw the pedigree chart, you will find the pattern of this maternal inheritance. And in that cohort, the metformin is contraindicated, and they may respond well to sulfonylureas. The other category is the syndromic diabetes, which is among them, the Wolfram syndrome or the DIG mode is the thing that we have to keep in our mind. It includes the insulin deficient diabetes and diabetes insipidus, optic atrophy, and deafness. And they present before the age of 16 years usually. And the diabetes can be the only presenting symptom in these patients. So we might miss these patients because the other features develop later in their life. So it's a must for us to observe these patients, all our patients, and to look for these features whether they are developing in their life. Okay, we'll see a case scenario now. A patient presented to us. So this is a 20-year-old gentleman from the state sector, from Hatton, comes with the history of diabetes mellitus for 3 years duration with poor control to oral hypoglycemic agents. He denies any past history of DKA, and currently also he's not having features of DKA, and no family history of diabetes mellitus, and his birth weight is 1.72 kilograms. Examination is unremarkable except for this BMI of 17.8 and no features of insulin resistance and insulin resistance. So these are the investigations available for us. HbA1c is 9.1 and UKB negative. And we have done stool elastase assessment, which is marginally high, which is negligible. And anti-GAD antibody is negative. And the imaging, ultrasound and scan and the CT abdomen is normal. The pancreas is normal. And we assessed C-peptide levels in this patient. Fasting C-peptide is 0.71 nanograms per milliliter, which is low. And we assessed the stimulated C-peptide levels as well, which is 2.05 nanograms per milliliter. That means which shows a response with the stimulation, but not a very good response. Anyhow, there's a response we could appreciate. So these are the typical patients that we encounter in our clinics. This is a thin male patient coming with diabetes without a history of family history or past history of diabetes or DKA history. And BMI is low and the C-peptides are marginally low. It's low anyhow and anyhow GAD is negative. So at this moment, what do you think? Does this patient belong to type 1 diabetes or type 2 diabetes? I would like to ask from you all, Don't get deviated because my topic is atypical diabetes. Just think of this and can you please hands up those who think that this patient is having type 1 diabetes? No one? Okay. Type 2 diabetes? Okay. 2, 3. Okay. So the hands are coming up straight. Okay, 4, 5. And any other form of diabetes? MODY, LADA, mitochondrial diabetes? No. Yes. We have to think at this moment, okay, where does our patient belongs to? So we'll see where our patient belongs to. Is he telling me the type 2 category? He doesn't have features of DK. Yes. So it can be type 2. And he has confirmed diabetes and GAD is negative. Anyhow, he's a lean patient and no features of insulin resistance in this patient. So this could be type 2, could not be as well. And then comes the type 1. Yes, he's 20 years, a young patient, a lean male, having diabetes, no features of insulin resistance, and the C-peptide levels are low. Yes, so he can be categorized as type 1 as well. But his GAT antibodies are negative and no past history of DKA. Absence of a DKA doesn't exclude the type 1 diabetes, but it is just, it is supporting our diagnosis. So that's not supporting our diagnosis. So, and also there's a rise in the stimulated C-peptide level. So my question is, the striking feature in this patient that we identified was the low BM. So can this be related to malnutrition? So when we go back to the history, there are cases explained in the history beginning from 1987. A French physician called Etienne Lancero has described this lean diabetes with the word diabetes grass in his paper in 1987. And then this malnutrition related diabetes has properly been described in 1955 by Dr. Hugh Jones as J-type diabetes in Jamaicans. He has identified this cohort as a separate entity in the patients who had malnutrition in Jamaica. And then in 1985, WHO has classified this entity as a separate entity and they have included it in their classification. But unfortunately, there had not been any adequate physiological basis for this. There had not been any studies to prove the pathophysiology behind this. So they have removed it from their classification in 1998. So there had been studies going on to identify the pathophysiology behind this, and countries including India, Uganda, Ethiopia, Jamaica, all those have been trying to identify the pathophysiology and they have done a lot of studies in this. And there's one person who pioneered for this recently. It is Professor Nihal Thomas, an endocrinologist, a great scientist from our neighborhood India. Very humble and nice person. I have personally met him. Actually, he's a very nice guy. So he has pioneered to assess the pathophysiology behind this type, that malnutrition related diabetes, along with his colleagues. So he has published an international consensus statement on classifying a distinct form of diabetes in lean individuals with a history of undernutrition. This was published very recently in the first week of October 2025 in the Lancet. So you have the free access for this, so you all can read this actually. So, but the studies began well before 2000, well before. So they have arranged a case control study to identify the characteristics of this cohort of patients with malnutrition. So, and as a result, they have published this in 2022, an atypical form of diabetes among individuals with low BMI. So I'll point out now the key characteristics that they have identified in this cohort. The first thing is the insulin deficiency. So they have assessed these patients And this blue line shows the patients with lean diabetes, and the lower down line shows the patients with type 1 diabetes. The patients with type 1 diabetes have very low insulin levels, almost zero, like they are absolutely insulinopenic. And here, this lean diabetes type also having insulin deficiency, and here lies the normal lean non-diabetic patients, the green line. So here in this analysis, they show they are having low insulin levels. In addition, in this graph, they have shown that the blood glucose levels are high in type 1 diabetic patients. It is denoted by the area under the curve. The glucose level is denoted by the area under the curve. So the type 1 diabetes patients have very low insulin levels, but their blood glucose levels are also high. And this when it comes to this blue line, the patients with lean diabetes, it's almost half-like. So their blood glucose levels are going to be low compared to the type 1 diabetes patients. So that is one characteristic that they have identified. And the other thing is the low hepatic glucose output and the preserved insulin sensitivity. So here, this category is denoted by the lean diabetes patients. So they have low hepatic glucose output compared to type 2 diabetic cohort who has a very high hepatic glucose output. And then when it comes to peripheral insulin sensitivity, the sensitivity in this blue group is high. It's almost equal like to the normal population. So they are insulin deficients having low hepatic glucose output with preserved insulin sensitivity. And the other thing is the low fat content. This was demonstrated in another study that was done by MR spectroscopy. And they have shown that young lean men in South India with low birth weight have low ectopic fat storage in liver and the muscle. And you have to keep in mind, because of this reason, these patients do not develop fatty liver as well. And the other characteristic is the low incretin levels. This study was carried out by Dr. Felix and the colleagues, and they have shown with OGTT and IGTT that even with stimulation, their GLP-1 levels are very low compared to the normal population. So when it comes to the pathophysiology, this undernutrition plays a role in mainly two cell types. It is pancreatic beta cells and the intestinal L cells. So this undernutrition alters this PDX1, which is responsible for beta cell proliferation, insulin gene expression, and finally it impairs the beta cell response and reduce insulin secretion. And in the L type, this pathway is hindered, PAK1 and beta-catenin, which are responsible for incretin secretion. So finally, the incretins are going to be low in these patients. So those are the characteristics that they have identified. In addition, they have excluded the following conditions in these patients. Those are slowly evolving immune-mediated diabetes, pancreatic diabetes, monogenic diabetes, lipodystrophies, and syndromic diabetes. That means the other atypical diabetes forms. So in conclusion, they have identified this cohort of patients age less than 30 years, BMI less than 19, with the history of IUGR or low birth weight, having low C-peptide levels, and no history of ketosis, along with the key characteristics that I described earlier. So these might need invasive investigations and sophisticated assessments and a lot of money, which is not available for us. But you can remember these things, because with these things, actually, we can get an idea about our patients. So this category was finally termed the type 5 diabetes. And now it is National Diabetes Federation, and this was recognized actually in last April in a conference held in India. So this will probably come to the ADA classification as well. we are looking forward for that. So why is it important to recognize this type? It's not the type recognition. We should have any advantage from this. And this study has shown that this cohort of patients, the majority, the 50% were managed with oral hypoglycemic agents, and 35% required insulin only, and 15% were on oral hypoglycemic and insulin. So the majority could be managed with oral hypoglycemic agents there. So what is the management that we can offer for these patients? We can give them oral hypoglycemic agents, mainly sulfonylurea, because I said that they have a defect in insulin secretion. So sulfonylureas can be given. Metformin, still yet to be studied, but for the cardioprotective effect and all, we can give them metformin as well. And then if they are not responding to oral hypoglycemic, we can move on to insulin. And mind you, they are having low BMI and then they are undernourished. So we need to optimize their nutrition and also to arrange exercises to strengthen their muscle mass. So where do we stand as Sri Lankans? Actually, it's not being studied yet, and now there is a study going on to assess the prevalence of type 5 diabetes and the characteristics of our patients. And I did a preliminary analysis, not a proper analysis actually, a preliminary analysis to see where we are standing. So I gathered data from our young onset diabetes database, which is run by 28 endocrine units in Sri Lanka. And this is the cohort that I selected. So we have roughly about 3,716 patients in our young onset diabetes database. And out of them, I selected the patients who belong to the age group of 16 and 30 years, because our cohort is going to be the patients are going to be less than 30 years. And so I excluded the youngest ones, and then who are having BMI of less than 19 and with a C-peptide level of less than 0.9 nanograms per milliliter. And these patients, some of them have undergone GAD antibodies and their GAD antibody levels are negative. And some cohort of patients have not undergone GAD antibody assessment. So this could be either type 1 also, but since we don't have data included in this criteria, we have a gray area because of the lack of facilities. So out of this cohort, 305 are type 1 diabetes patients, 112 are type 2 diabetes patients, and 12, their diagnosis is not sure. I mean, it's mentioned instead. And out of this 429, 302 patients are on insulin only. And majority of them are on basal bolus regime. That means they are getting either 4 or 5 insulin injections per day. And 52 are on oral hypoglycemics only. And 75 patients are on insulin and oral hypoglycemic agents. So roughly to show with the studies, so the majority are type 1 patients and the majority are on insulin. So why is it important? I mean, we have a gray area because of the lack of facilities. We don't have GAD antibodies and C-peptide levels freely available. So if you think about these patients, they may be having type 1, but these patients might belong to type 5 diabetes as well. So rather than, if we diagnose them correctly, rather than putting them on lifelong insulin, we might have tried them on oral hypoglycemic as well, which would improve their quality of life, which would affect them good for their psychological health. So we can make a change actually if we think about that. So give it a thought, think about that. And when a patient presents to you and sits in front of you, think what could be the diabetes type in my patient, and whether it is a form of atypical diabetes, including type 5 diabetes, and try to make a difference and try to do the best for your patient. And don't forget to ask the birth weight of your patient. The patient might think, oh, what's wrong with this doctor? And I came to take medicines for diabetes, but he's asking my birth weight. But now you have to make it a routine in your practice. You have to ask birth weight of your patients and keep it in mind as well. So, at last, to be the detective and move from pattern recognition to physiological and genetic assessments and use these resources. The radiant network, as I mentioned earlier, and there are more calculators and genetic counseling facilities available. Use them and bring our future diabetology in a way that we serve our patients in a truly personalized, effective, and safer care for every patient. So these are my references. Thank you very much, and special thanks to my trainers, Dr. Charles Anthony Pillay and Dr. Sonali Gunatilaka, who is here today with me, and to my parents and all who have helped me in this journey. Thank you so much.
The presentation is now open for discussion. In your analysis, were you really able to, pinpoint and detect some real type 5s in our database?
The thing is, yeah.
Negative and fulfilling other criteria.
The other criteria means in their things, they have to exclude the other secondary causes as well, mainly the pancreatic diabetes and monogenic diabetes and other types. Okay. What we have done in our assessment, in our database, what we have, the most of the data are lacking because of the lack of facilities. So we don't have yet antibodies, C-peptides. So there are some patients whom we are managing as possible type 1 diabetes who still doesn't have a C-peptide value. Because of the clinical phenotype only we are managing. So in that setting, it was very difficult to recognize this exactly these patients could be type 5 diabetes like.
Is it essential to do the stimulated C-peptide to rule out type 5? Or?
Yeah, I think it's better if we can do, because even in type 1 diabetes, if they are in the honeymoon period, they may, the type 1 diabetes also, that they don't, if it is a burnout disease, they won't show a response. If it is in honeymoon period, they might show a response. And it's but depending on the year, if we have past 3 years with the diagnosis of diabetes duration, so we might think, okay, now it is the time is enough for the type 1 patients to have a low C-peptide level. So we have to decide that depending on all the things. And however, in the studies carried out by this Indian team, they have assessed it and they have not mentioned it as a must, but they have assessed it because they can show a response. They can show that there's a kind of insulin reserve there and it can be grabbed out.
Essentially, GAD has to be.
It's not only GAD actually. If it is possible, we have to do the other antibodies for type 1 as well, like insulin antigen 2, zinc transporter 8, and the insulin antibodies. But they have specifically mentioned at least you can do GAD65, and if it is negative, you can consider. But in the UK setting, for the diagnosis of type 1, they don't go ahead with one antibody actually. So they think, they consider at least 2 antibodies must be positive to diagnose type 1 also. So in that case, there are some gray areas, there are controversies which are yet to be studied.
Thank you. Any other questions?
Thank you, Isha, for the presentation. Actually, this is a small clarification. What this highlights in our study is there is a cohort which might belong to this type 5 diabetes. We might miss thinking it's type 1 or type 2. So it's an eye-opener for us to think of type 5 diabetes rather than just blindly categorizing as young type 2 or type 1 diabetes. My question is, what is the prognosis of this type 5 diabetes? Is it well known, or what's your opinion?
Yes, when it comes to prognosis, outcome, and the behavior of this category, actually it's not yet been studied because it It's only now they identified this phenotype. It's only they define the characteristics and identify. So probably we need some more studies. We need prospective studies to follow up these patients and to see how they are behaving in the future, to identify the outcome and the outcomes in these patients.